All right, thank you everyone for joining us tonight on our cutaneous cancer section webinar, exploring controversies in the management of the cutaneous malignant melanoma of the head and neck. Just a quick shout out for our international conference that is going to be in July in Montreal. Join us and we hope to see you there in person. And then if you are not yet a member, we want to encourage you to apply online. The link is here as well. So we'll go ahead and get started. I'm really excited to have this group of panelists joining us today. We have like a really great multidisciplinary panel. And so I'm just going to go ahead and briefly introduce everybody, but we'll just go ahead, jump in and get started. So first we have Kerwin Shannon. He is a head and neck surgeon from all the way from Australia. He works at Melanoma Institute Australia. We have Kelly Malloy, another head and neck surgeon joining us from the University of Michigan. We have Leslie Fetcher. She is our medical oncologist, also joining us from the University of Michigan. Devarati Mitra is our radiation oncologist, joining us from MD Anderson Cancer Center. Jane Messina is our dermatopathologist joining us from Moffitt Cancer Center in Florida. And then lastly, we have Mary Stevenson, our Mohs surgeon, who is joining us from New York University. Okay, so we'll jump right in, go ahead and get started with the patient case. So we have a 22-year-old woman, a psychology student, works in retail, past medical history is just significant for anxiety and OCD, no personal history of cutaneous malignancies. And she presented with a post-auricular pimple that slowly progressed to a dark lump. This was biopsied, and on the outside pathology report, it noted to be consistent with nodular malignant melanoma. The depth was 4.9 millimeters with impending ulceration. But on internal review of the slides, the depth was consistent with 2.4 millimeters, and there was no ulceration noted. PET CT for staging and MRI brain were obtained, and these were all negative. And so for her stage, she is a T3A N0M0 stage 2A. And given the pathologic information we have from the biopsy, from the NCCN guidelines, it's clear that this patient warrants a wide local excision with sentinel node biopsy. So this brings me to my first question for Dr. Shannon. Is there ever a situation when sentinel node biopsy could be considered for thinner melanomas?
Yes, and this is actually happening more often than not at the moment. This NCCN guidelines and our Australian ones would suggest that a node biopsy is recommended for a perceived risk of node positivity 10% or greater, that it should be considered or discussed if it's between 5 and 10. But if it's less than 5%, it would probably not be recommended. Now, T1s overall have an overall positivity rate of somewhere between 5 and 6%, so you would think that there's probably no great role for it. But in fact, when we looked at our long-term outcomes for people with T1 melanomas, it's interesting that there is still significant morbidity, that mortality doesn't drop over time, and that there's a significant number of deaths that occur late. So there's this group of patients in amongst the T1s who are going to have bad outcomes, and like melanomas of most thicknesses, you'd expect that that the status of the sentinel nodes would predict those people that are going to not do so well. Just have the next slide. Mm-hmm. There's a whole heap of publications that have highlighted the sorts of risk factors that would be involved, and we've actually put together a calculator which has been published. There's another one I think that Sloan Kettering put out years ago, but risk factors that have been shown to be important are age, Breslow thickness, obviously. The thicker, thin tumours still do worse than the thinner ones. The type of melanoma is important, whether or not there are detectable mitoses, whether or not there's ulceration, and in our experience, lymphovascular invasion is also important. And as an example of that, if you put up, just follow on, this is a real live case from a concerned GP who wrote to us complaining that our calculator was doing patients real harm, because here was this 27-year-old who had no bad features in her melanoma, but had a calculated risk of about 15%. But in reality, she is young. There are detectable mitoses. And even with those confidence intervals, the risk is still above 10%. So there are those people out there. Next slide. To summarize it all up, the guidelines would suggest that the T1B tumours Those ones bigger than 0.8, and those outcomes that I showed you on the previous slide were some of the evidence for that. Tumors with ulceration, the young patients, detectable mitoses, lymphovascular invasion. There are some publications out there suggesting that the head and neck as a primary site is something that should be considered as well.
Okay, thank you. So the development of gene expression profiling prognostic tests has shown independent value in the risk stratification for patients stage 1 to 3 for cutaneous melanoma in a lot of studies, but is not yet incorporated in our NCCN guidelines. So Dr. Messina, what is known right now for the role that gene expression profiling can play in guiding management and or surveillance for cutaneous melanoma?
Thanks for the opportunity to talk about this. I mean, I can actually summarize it by saying what you just did. It's not yet incorporated. In fact, the NCCN would prefer or does not endorse the use of predictive testing unless it's at part of a prospective trial. And we don't use them at Moffitt to guide any decision making. So basically the slides I have are going to show the potential uses given a proper prospective trial and some of the abundance of data that you touched on that does show that they have is powerful, if not in some cases more powerful, means of predicting recurrence. So, you know, this just kind of summarizes the potential uses in terms of cost saving and decision making for predictive tests based on various stages. So for patients with a clinical stage 1 lesion, which is a high percentage of newly diagnosed patients, if you had a test that could predict who's going to have a negative sentinel node, you could potentially save, you know, $25,000 a case. A little bit thicker melanomas. Now you get into decisions for adjuvant treatment, and then patients with nodal disease, you know, decisions for adjuvant treatment or not, especially for the 3As with micrometastases, as well as decisions for more aggressive follow-up. So I mean, if we could predict significantly low risk patients in any of these categories enough to forego treatment, that would the cost savings is very obvious. The issue is we haven't yet done that golden prospective trial similar to what was done, for example, in breast cancer with the Taylor, where they actually took patients and stratified them to treatment or no treatment based on the risk score. So the following slides just briefly summarize, and it's way too much to look at and absorb the numbers, but they summarize the 3 currently available gene expression profiling tests. The newer kid on the block is the so-called Skyline test, which combines 8 genes and clinical pathologic factors, and has a pretty great negative predictive value in identifying patients that have a very, you know, negligible risk of having a sentinel node positivity. And this is the data for the largest cohort of 754 patients. And in this was not used prospectively, but if had been used, it could have potentially reduced the number of sentinel node biopsies in this group by 42%. And using it did have a higher predictive value than the previously mentioned nomogram. So this was very tempting data. So the next slide currently shows, I think, what's going to answer the question is this test useful? Because there's a current prospective trial going on right now, aiming to target 2,300 patients from 9 institutions that would otherwise that are going to undergo sentinel node biopsy. Clinicians and patients will be blinded to the results, but it will identify hopefully patients at a less than 5% chance of having a sentinel node biopsy with this binary classifier. Predict in the future, potentially saving some patients from this procedure. So I think University of Michigan's participating. I don't know about others here, but no, so far they're doing pretty well with accrual. The next few slides I'm going to go through quickly because they show the results of this Skyline assay for predicting recurrence. And these are just survival curves showing patients with a higher risk have higher relapse-free, distant metastasis-free, and melanoma-specific survival. And the next slide shows that even in patients that are lower stage where maybe they're, it's not quite indicated to do chemo yet, but we may consider it or look for higher risk patients, you can definitely find 2 different risk groups using this classifier in that subset of patients. And then the other 2 tests are next, we have the one that's probably been around the longest, the Castle test, that has the greatest number of retrospective and prospective studies showing that there's it's different, that it can predict patients at higher risk of recurrence, metastasis, and in fact, death at 3 years. The next slide, this is prospective studies. This is an example of a report. You get a class 1A, 1B, 2A, or 2B, predicting your risk of recurrence or metastasis in 5 years. The next one shows the plethora of retrospective studies showing at 5 years, same thing, significant difference. The survival curves are going to separate. The question is just, we don't have a prospective trial showing what we're going to do with this data. The final test is the Malignant test by Narracare, and a couple of retrospective studies have shown, again, a strong ability to separate patients at high risk of recurrence and metastasis. And this one, in fact, is the most promising because it is the centerpiece of a current ongoing trial where patients with stage 2 disease, 2A to 2C, are stratified by their risk score, and those at high risk will be are being randomized to nivolumab versus observation, and then observation for low risk. So that so the answer to your question is, we don't know how to use them yet, but I think we will very soon.
Thank you, Dr. Messina. That's very good information there. So based on the NCCN guidelines, Mohs is not recommended for primary treatment of invasive cutaneous melanoma, especially when standard clinical margins can be obtained. And even when Mohs is performed, permanent section analysis of that specimen is strongly recommended. However, there are some Mohs surgeons that are treating melanoma, even for invasive melanoma. So my next question is for Dr. Stevenson. Are there certain situations for when Mohs could be considered in the management for melanoma, and how do outcomes differ?
Well, first, thank you so much for having me. I think it's a great question. It's really nice to be talking with colleagues that are interdisciplinary. In general, when Mohs is used for melanoma, it's usually used for melanoma in situ, which is on areas like the face, ears, or scalp, with the idea being that it is tissue sparing. And paraffin embedded blocks are generally recommended, and I'd say the majority of Mohs surgeons do send them. I think the things you're worried about are invasive melanomas or missing a desmoplastic melanoma. And some surgeons, although I'd say it's a more limited number, do use it for invasive melanoma. More commonly, if that's the case, it's for residual melanoma in situ at the borders of a melanoma. And usually, that would only be a T1A tumor. So the central deep poke is very important. And I think for the majority of most cases for basal cell and squamous cell, we take 1 to 2 millimeters as our margin. For melanoma in situ, most surgeons are not doing this. They're taking something like a 0.5 centimeter to 1 centimeter on their first stage for melanoma. So I think this is where things get a little bit tricky as to what are we gaining by doing Mohs for melanoma. Obviously, we're gaining complete circumferential, peripheral, and deep margin control instead of bread loafing. And we're also having reconstruction on the day of surgery. So for the majority of my patients, when I do a basal cell or squamous cell, the tumor is removed, 100% of the margin is analyzed, they're tumor-free, and the reconstruction occurs that very same stage. So that microscopic assurance versus some statistical likelihood with a known margin that you will, fall in the N of 95% of people that do well with your early stage, I think is one of the advantages. And if you go to the next slide, I think the biggest problem we have with Mohs for melanoma is that we have no prospective studies. So everything is retrospective. We have meta-analyses that support the lowest recurrence rate with Mohs, followed by stage excision, followed by wide local excision, but nothing is prospective. Next slide. I always tell my residents in places that don't have Mohs surgery, they always say, oh, we're going to do slow Mohs, meaning they're going to do a stage excision. So they're going to take a standard margin for melanoma in situ, like 0.5 centimeter around the lesion, and then they're not going to close it. So unlike on the leg, if it's on a cheek, they're going to wait, they're going to send it to pathology for paraffin embedded blocks. And then once everything's clear, or they rush the pathology 1 or 2 days later, they do the reconstruction. So this is not Mohs because you're not analyzing the margins completely. If you go to the next slide, I'm sure you're all familiar, but I think sometimes this is overlooked. When you do a surgical excision, you have bread loafing of your specimen and you can miss tumor. So we generally go by standard margins, which I think in Mohs is really important because there's data from Sloan Kettering, Kishore and Hall that looks at the rate of positive margins with melanoma in situ on the face and lentigo malignas. And actually, it's not 0.5 centimeter. Generally speaking, the margin you have to take to clear those tumors is something like 0.6 to 0.8 centimeters. So if you go to the next slide, that's the positive tumor you would be missing. This is Mohs. I'm sure you all understand this, but I think about it like a Reese's peanut butter cup. So the way we take our specimen in particular is with the beveled edge, and the debulk would be from the center, right? It would be the peanut butter cup in Mohs for melanoma in situ, but then we're actually laying the wrapper flat and looking at 100% of it rather than picking a couple of slices of toast out of a loaf of bread and saying, if we don't see it in the crust, we're good to go. So if you go to the next slide, I think you covered this in the question, which is great, but generally speaking, it's sharply debulked. It's submitted for permanence. The average initial size of a margin is 0.5 centimeter, which is what we would do with a stage excision, which is what I currently do. My institution is starting to bring on MART1, which is the staining that you use most commonly. It's a hard stain. It's a more difficult stain to see under frozens. Not that it can't be seen and people are excellent at it, but it takes some time to get your histotech good at it and to get good at seeing it yourself. And that's generally how it's done. So to me, I think one of the questions is, what are we gaining if we're taking the same initial margin for the most part? I mean, I think if we had prospective studies, we might become more tissue sparing, but we don't have those yet. So if I'm doing a stage excision where I'm taking 0.5 centimeter, rushing my pathology and finding it's clear, and then 2 or 3 days reconstructing it, in a Mohs first stage, you're doing something similar. So what you're gaining is that 100% margin analysis. But do we have data to say, besides meta-analyses or things that are looking back, that improves survival or outcomes? We don't have that prospectively. Next slide. So this is just an example of what we do. You can see in the center the debulk, and then you can see kind of the peripheral moat around it, or the Mohs stage that is then being looked at 100%. And you can see it also being inked and mapped appropriately. You go on to the next slide.
I think that's the last slide there.
Okay.
Okay,
So
great.
I think, the takeaway here is we need prospective data. And yes, 100% margin analysis. The advantages would be 100% margin analysis, and patients would leave same day reconstructed. They're not waiting for a couple of days to get their pathology back, but the former, I think, is much more important.
Great, thank you so much. Okay, so proceeding with our case. So our patient, she underwent a wide local excision, sentinel node biopsy, and on final pathology, there was no residual invasive melanoma seen. And so her final depth is 2.4 millimeters. No sentinel nodes, or there were 3 sentinel nodes, 0 out of the 3. It was all negative. And so her final stage remained at PT3A and 0 stage 2A. So Dr. Mitra, when would you consider offering adjuvant radiation to the primary melanoma site?
So thanks again for giving me a chance to kind of talk about this subject. I think radiation in the setting of melanoma is a always evolving concept. And we just have to think about what is the goal of radiation when we do administer it, which in the adjuvant setting is to decrease recurrence risk. And recurrence risk of what? So if we're thinking about the primary site, to decrease local recurrence risk. And if we're looking at nodes, to decrease nodal recurrence risk. Next. So what are the things that drive local recurrence? For this, we look sort of at historical data. Unfortunately, this is a lot of kind of retrospective single institution, large cohort things, but it gives us a sense of what are the factors that increase the likelihood that a melanoma is going to come back. For example, let's start with where it first appeared. I think the one kind of melanoma that everybody's more or less on the same page about is desmoplastic melanoma. This is an entity where it seems very, very likely that local recurrence will drive the pattern of recurrence, and additional adjuvant therapy targeting local recurrence is worthwhile. Other things are a little bit more gray. So thicker melanomas we know are more likely to come back. Things that have ulceration more likely to come back. Things that are in a challenging resectable area. So as everyone on this call, basically in the head and neck area, microsatellitosis, probably evolving evidence that that may be a particularly strong driver. And then perineural invasion, also studies looking at that as a potential driver. Next. So to break it down one at a time. So technically a desmoplastic melanoma needs to have greater than 90% desmoplastic morphology. Some of our centers that refer to us actually forget this and will call things desmoplastic melanoma just for having desmoplastic features. But the evidence is you really need greater than 90% to be desmoplastic in truth. Now, it seems like this is a unique biologic entity that has potentially a lower risk of nodal and metastatic progression, but rather a particularly high risk of local recurrence. There's these two studies, one from MD Anderson, one from Moffitt, that showed that radiation can put a significant dent in the likelihood of local recurrence. Again, these are retrospective studies, but essentially both showed the same thing. Local recurrence significantly improved with the addition of adjuvant radiation. On a side note, study from Moffitt also showed, perhaps not surprisingly, that positive margins are problematic. So another thing, as with most entities, increases the risk of local recurrence. Next slide. And this is one I sort of touched on in the beginning, which is microsatellitosis. So we know microsatellitosis is problematic in melanoma. In and of itself, it actually upstages someone to stage 3. However, it isn't just distant or nodal disease that this is predicting for in transit. It actually predicts potentially for local recurrence as well. Both our experience here and of the Sentinel Lymph Node Working Group showed that it's really microsatellitosis that's one of the primary drivers of local recurrence. And that probably is not surprising. If you have multiple kind of scattered deposits of melanoma in your field, there may be a residual microscopic disease beyond what you're thinking about. And so for us, at least, this is a major, major driver of consideration of adjuvant radiation. Next. So when do we recommend adjuvant radiation to the primary site? So this is sort of just our paradigm. One is desmoplastic melanoma, another is a positive margin. We've added microsatellitosis to that kind of list. And then the other one is basically a melanoma that's already recurred locally, sort of telling us a little something about the biology and what we expect in the future based on what's happened in the past. Now, the other risk factors are very real, but we sort of think about them as a constellation of things. So it's not really that any individual other risk factor will necessarily drive us, but a combination. For example, something that's thick and ulcerated with PNI in a challenging to re-resect location, that's someone we would consider. But probably one of the most common examples is a kind of thick melanoma on the head and neck that has PNI. That's someone where we would recommend adjuvant to the primary, for example. Next.
All right. Thank you very much, Dr. Mitra. So Dr. Malloy, to get the surgical perspective, historically, we would have offered a completion lymphadenectomy for any patients that had positive sentinel nodes. So how have the MSLT1 and 2 data impacted your approach for these patients?
Sure. And I apologize. I'm really thankful to be here. I have a whiny dog who I did just take a quick moment to feed this evening, but you may hear her because she seems unhappy in the background. So thank you for this opportunity. I think this is a great topic to understand, how we adopt surgical practices and how we interpret, the buy-in to surgical data and how different it is with how it's evolved over the years. MSLT1, began reporting out, around, the early 2000s, and it was a source of incredible debate for many years, decades. And it's kind of interesting now that we really do, I think at this point, take it, I wouldn't say for granted, but it really has been, it's now a classic body of work. It's, deemed really incontrovertible, I think, at this point. We have incorporated sentinel node into our guidelines. It is widely practiced, and that is because MSLT1 and its many updated reports over the years demonstrated that sentinel lymph node biopsy is reliable, it is accurate, it is safe. There's a very low risk profile to it, low complication rate, it's well tolerated. And importantly, the various reports of the MSLT1 trial demonstrated that it is the most important predictor of survival and outcome for these patients. So I think that is, something that we all now accept, that and why that we see sentinel lymph node biopsy, in wide adoption at this point. There were concerns initially, as with any trial, when you have relatively few, say, head and neck patients, concerns about nodal drainage patterns, reliability in the head and neck. I think subsequent studies, including ones published out of my own institution, demonstrated that that this is no longer a concern in the head and neck, and so it has been widely adopted. By way of contrast, MSLT2 was really very exciting data published in 2017, and also I would note accompanied by the German Dermatologic Cooperative Oncology Group selective lymphadenectomy trial, DCOG SLT, which was published slightly before it. But the German group did not include head and neck cancer patients in it, but the data was very consistent with MSLT2. Both trials compared observation protocols, intentional active observation with imaging, to completion lymphadenectomy. So as you mentioned, Dr. Choi, that prior to this trial, patients with positive sentinel nodes went directly to completion lymphadenectomy. Sometimes that was a extended neck dissection. Sometimes that was a parotidectomy and neck dissection, depending on the nodal patterns. So these trials demonstrated very clearly that completion lymphadenectomy does not improve melanoma-specific survival in our positive patients. There is evidence that the completion lymphadenectomy improves regional recurrence rate. There is a small improvement in disease-free survival with completion lymphadenectomy, which is likely due to improved regional control when in our case for head and neck patients, when the neck is dissected. But this is really a game changer in terms of how we think about counseling patients and what the goals of these various interventions really are. The takeaways really from MSLT2 are that, observation is equivalent in terms of melanoma-specific survival. And I think for us as surgeons, there was still concern after this trial with the relatively low rate of head and neck included patients, around 13, I think it was 13.7% of the patients included in MSLT2 actually were head and neck melanoma patients. Was this data really widely applicable? And were there going to be impacts of us observing patients in the neck that would be unforeseen, particularly with the very intricate anatomy that we're dealing with, the proximity to cranial nerves, function, and should we, can we apply this data? So let's talk a little bit, let's go to the next slide, about adoption of what we learned from MSLT2. Some of my colleagues here who are health services researchers looked at adoption and really were able to define it over the 3 years after MSLT2 was published. You can see here with the percentages, the year before the trial was 67% of our patients, all comers, all sites, went on to completion lymphadenectomy in the context of a positive sentinel node. That dropped to 33% in the year after MSLT2 was published, and then dropped again to 26%. What was interesting is that we could still see in our data that concerns around nodal burden, and I mentioned that briefly on the last slide, but nodal burden seems to be an important thing to consider here. I think MSLT2, as well as DCOG SLT, had a preponderance of low nodal burden patients in the data. It just is what it is. And so it was very hard to, again, generalize to patients who have more, greater than 1 millimeter of nodal metastasis in the sentinel node, because it was harder to make good generalized recommendations around those patients because they were so largely not absent, but just most of the patients that we see in these trials are going to have true micrometastases. So when patients in our group had larger nodal burden above 1 millimeter, we tended to move towards completion lymphadenectomy in those early years. I would also note here, very importantly for this discussion, is that our head and neck patients initially were also more likely to undergo completion neck dissection, 59% versus 33%, with that this was a significant difference. And so that really reflects, I think, the concerns about, what we can generalize from MSLT2 and what at the time we could not comfortably generalize. So let's go to the next slide. And now there are 2 publications that out of a multi-institutional international group. These are retrospective studies, cohort studies that looked at MSLT2 adoption and trying to find out about some of those patients that we worry the most about, the high-risk patients that we need to advise from time to time. And so the first study here demonstrates that 84% of patients in the years after MSLT2 was published went on to active surveillance protocols, which is really a tremendous level of adoption of this data, which is, I think as surgeons, sometimes we are slow to adopt, but this is a really impressive, rapid adoption of the data. And another point that I wanted to make sure that we made here, there was still an association in this group that there was some, there was still an advantage for those who did go on to completion lymphadenectomies. There was a diminishment in the risk of nodal recurrence, but not meaningful survival differences in terms of melanoma-specific survival and overall survival. So again, this confirmed the findings in practice of MSLT2. The second study is kind of interesting in that it starts to look at the patients that we probably worry the most about. What do you do with a patient who has a larger nodal metastasis, whose sentinel node might have ENE, who might have more than 1 positive sentinel lymph node, and then those patients that Dr. Mitra was just talking about who have microsatellites, how do we advise them when they have a positive sentinel node? This study did demonstrate that they are higher risk. They have a 2 times increased risk of recurrence, but that these patients do appear, these 2 were enrolled with some consistency in observation, active observation with serial ultrasound. And that perhaps at this point, given the exciting developments in adjuvant therapies, that these patients can now be identified as high risk and then be appropriately managed beyond completion lymphadenectomy. So the information that we're getting from the sentinel node, while very important from a prognostic perspective, is also critically important for us to be able to put people into appropriate trials and appropriate therapeutics that may not include completion surgery in the future. I will fully admit that this is still, I would call this still the more controversial aspect, but it's very interesting to see this data come forward and to discuss it at our multidisciplinary tumor boards, because we occasionally will have these patients who have more than 1 positive node who really do not want to go on to a completion neck dissection, and to be able to think about it and have data to support decision-making to go on surveillance protocols is very, very important. I think from my perspective, how do we have to still counsel our patients? I think the patients need to understand the data, what is going to be accomplished with completion neck dissection versus observation. If we are going to enroll patients in observation trials and observation protocols, I should say, the reality is that they have to understand how important it is that they comply with them. There are going to be situations where patients may not be able to return to a center of expertise in ultrasound that, on a reliable basis, every 3 months, every 4 months for a certain number of years to comply with these protocols. If that is the case, consideration of completion lymphadenectomy may still be appropriate, but it's important that we understand this data so we can work through it with our patients and be able to advise them appropriately. Thank you.
Thank you so much, Dr. Malloy. So, Dr. Fetcher, is there a role for immunotherapy or targeted therapy for a patient with a positive sentinel node?
Dr. Choi and the panel, thank you so much for allowing me to contribute to this. So I'm going to answer this with a big possibly, and I apologize I did animation, so I'm going to give you some work to do. Keep clicking, you can just keep loading up the slide. I think it's always good to just remind everyone of our current adjuvant therapy options. So I'm still going to emphasize that close observation is still an option in the setting of resected stage 3 disease. High-dose interferon at this point is pretty much not used and not recommended. We have ipilimumab at 3 dosing schedules where 10 milligram per kilogram would not be recommended. Pembrolizumab, a PD-1 inhibitor, nivolumab, a PD-1 inhibitor, as well as dabrafenib and trametinib if BRAF mutant present. I want to emphasize a couple things, and this has been a fantastic data support to my statements here. One, when we talk about the staging that was used, most of the adjuvant studies were still performed when we were doing adjuvant, AJCC 7th edition, and there is quite a bit of variability in the stage 3 categories between 7th and 8th edition. I think that's critical when I start trying to apply the data from these adjuvant studies. 2, most of the patients had a completion lymph node dissection because this was prior to MSLT2. And so I personally feel that the decision of whether or not to do a completion lymph node dissection or a nodal observation is an independent decision from whether or not somebody should be getting any kind of systemic therapy. We have no data to say that we are swapping surgery for systemic therapy at this point in time. And then I think the sentinel lymph node burden also is critical. For many of the studies, they did not allow stage 3A patients, or if they did, they required at least a 1 millimeter deposit in the sentinel node. And I think that's important to factor into the decision making. Could you advance, please? So just as a reminder of kind of our big categories of systemic therapies, we have immunotherapies, and in the schematic on the left, you can see the CTLA4 and PD-1 interface between APCs and T cells. And then on the lower aspect, you can see LAG3 and PD-1 and the tumor cell T cell interface, where LAG3 at this point is only FDA approved in the more advanced disease setting. For targeted therapy options, we have 3 BRAF inhibitors, vemurafenib, dabrafenib, and encorafenib, and then MEK inhibitors, cobimetinib, trametinib, and binimetinib, where BRAF mutations are present in approximately 40% of cutaneous melanomas. In the adjuvant setting, only dabrafenib in combination with trametinib is FDA approved. Can you advance, please? So I gave you a lot of data, my apologies, but this is at least a summary slide of most of the adjuvant trials that we consider. So first at the top, I'm going to talk about dabrafenib, trametinib compared with placebos or combi-AD. And then the remainders are going to be primarily all immunotherapy studies, including ipilimumab 10 milligrams per kilogram versus placebo, nivolumab 3 milligrams per kilogram versus IPI-10, and this is Checkmate 238, which led to the FDA approval in the adjuvant setting of nivolumab. We have Keynote 054, so this is pembrolizumab versus placebo. We have Checkmate 915. This is one of the few studies that was done with the 8th edition staging and did not require completion lymph node dissections. And this compared Ipi-Nivo, again with alternative dosing to what we use in the metastatic setting, versus Nivo 480. Of note, this was a negative study. Ipi-3 versus Ipi-10 versus high-dose interferon and ECOG 1609. We have the Immune-D study, and again, this was all in resected stage 4 patients. And then we have SWOG 1404, pembrolizumab versus standard of care, where standard of care was defined as high-dose interferon or Ipi-10 at the time that the study was started. So one, you can see that these are large studies. 2, I emphasize, again, 7th edition staging, as well as the criteria for involvement. Again, we have 3As. We're not included in all of them, specifically like 238 did not include 3As, but that 1 millimeter deposit in the sentinel node was a factor in most of these that included that. We have a range of follow-up going from approximately 2 to 7 years. And we have a relapse-free survival benefit, overall survival benefit, toxicities in the grade 3-4 category, as well as deaths, which I think are important to consider, especially in the adjuvant setting. The takeaway, if you can appreciate it, is the vast majority of these showed a relapse-free survival benefit. The exception is that Checkmate 915 that we just mentioned, that was a negative study. The overall survival benefit is a little bit more dicey, if you will. So one, for dabrafenib and trametinib, this did not meet the pre-specified statistical significance. So this was not a statistically significant overall survival benefit compared to placebos. And this was at the 3-year mark. We do have a survival benefit for ipilimumab, 10 milligrams per kilogram compared to placebo, but this comes with quite a bit of toxicity, and that has led to its lack of use in the real world setting. IPI 3 mg per kg versus IPI 10 did not show a survival benefit, and this is at the 5-year mark. We have not reported overall survival data for these two studies. We do have a survival benefit for IPI 3 compared to interferon from 1609, but this was not reproduced for IPI 10 versus interferon. There was a survival benefit again for, this is traditional metastatic setting doses of IPI 3 Nivo 1, but again, this was in resected stage 4 only, and this does come with significant toxicities with a 71% risk of grade 3-4 toxicities. And then pembrolizumab did not show a survival benefit compared to standard of care arm. Next slide, please. So I see this as a balancing act for adjuvant therapy. First and foremost, one of the most important things is what are we hoping to accomplish, just like Dr. Mitra had said. One, I think the first step is to consider the prognosis of the patient. In stage 3A patients, we can have survival potentially at 5 and 10 years that is melanoma specific, as high as 93 and 88%. So one of the big questions is, are we actually going to improve the outcomes of some of these people by giving them adjuvant therapy? 2, the vast majority of these have a relapse-free survival benefit. And I think this is one of the ultimate questions in the melanoma community is that enough for you? And is that enough for the patient that you are talking to? They may have unknown or absent overall survival benefits. I tend to think of melanoma as a lifelong risk. So am I really impacting their outcome by shifting their relapse by a few months? Potentially. I may not be. But I think one of the other realities is there's plenty of people who are going to have toxicities, and some of these can be, 1, life-threatening, like myocarditis or Guillain-Barré syndrome, but 2, they can also be permanent. So the endocrinopathies and adrenal insufficiency and type 1 diabetes, while they are rare, do happen and should not be underestimated of the lifelong impact those could have for some of our patients. Are we having a selective pressure and resistance issue? Do we want to use these now when these are the agents that we have to use in the metastatic setting? Do we potentially compromise response to future treatment? And is NED status really the appropriate context for ICI use? Please advance. So neoadjuvant therapy, and this is just one representative study, is one of the questions when we start talking about immunotherapy is it better to actually expose the patient to immunotherapy when there is still tumor in place? And this is the schema for SWOG 1801, which was recently published in the New England Journal. This was a randomized phase 2 study. And while neoadjuvant trials have been going on for a little while now, they tend to be fairly small. Definitely, we've had one out of Dr. Shannon's institutions, several out of Dr. Shannon's institutions. But I think this is the challenge, is stage 3 is actually also a wide variety of different presentations. It's not just one manifestation that everybody should get the same treatment, in my opinion. So this was involving resectable stage 3B, C, as well as 4, as high up as stage 4 M1C. And the primary endpoint was event-free survival. And everybody got 18 doses of pembro, but they were randomized to either standard surgery and then 18 doses adjuvantly versus 3 doses, then surgery, and then 15 additional doses adjuvantly. Please advance. One, you can see that the report showed a significant improvement in event-free survival in the neoadjuvant adjuvant group compared to adjuvant only. From a RECIST response criteria, we saw a 6% CR rate and a 41% PR rate in the neoadjuvant group. On review of institutional pathology reports after neoadjuvant therapy in 132 patients, 21% had a path CR. And one more click. Thank you. And toxicity seemed reasonable and acceptable both in the neoadjuvant treatment phase, the surgery, as well as adjuvant treatment phase. Keep going. Thank you. I think another big question is, if we are going to expose our patients to some of these therapies, what happens when we try and treat people who have already progressed after some of these? I don't have to explain to you that when people have progressed on BRAF/MEK inhibitors, unfortunately, that can be fairly rapid. If people have progressed after PD-1 therapy, one of the first things we think of is, well, what exactly does that mean? Is it while they're actively receiving PD-1 therapy? I think we can all appreciate that if somebody has cancer growing on an active treatment, that is by definition poor prognosis with a low chance of response. There's really no reason to continue PD-1 therapy if somebody is growing on that therapy. Progression after PD-1 therapy, again, I think there's a wide variety there. Is it kind of, what is the timing? Have they completed adjuvant therapy or even metastatic therapy? And what is the time frame from the end of their prior therapy to the next subsequent relapse? They could potentially respond to single agent PD-1 again, but not if that was a rapid progression after completing therapy. And we want to think about the treatment options that we would then use. So in the setting of somebody who has progressed after PD-1, response rates that have been reported for IPI single agent is approximately 13%. For IPI with Nivo, the response rate's 31%. And I want to remind you that in the primary first line setting for IPI Nivo, the response rates are typically going to be more in the 50% range. And then BRAF/MEK inhibitors, typical response rates can range from 70 to 90%. And again, we see that in the first line setting as well. Please advance. I want to reflect on an international high-risk melanoma consortium paper where 21 melanoma referral centers in both the US, Europe, UK, and Australia reported on treatment in the adjuvant setting from 2017 to 2019. It involved greater than 1,000 patients. Completion lymph node dissection use, just as Dr. Malloy referred to, decreased. Adjuvant systemic therapy increased during this time frames. And the thing that they noted influenced the decision-making was nodal tumor size, stage, as well as the location of the treating center. One more click, please. So if it feels like everybody might be doing something different, I think this actually is a nice graphic that appeals to all of this. On the left hand of the screen, you can see for 3A patients, Australia, Europe, USA, and then all. You can see that there is really no use of completion lymph node dissections and really nodal observation with or without adjuvant therapy, and then a variation amongst the others. But I think you can see that for stage 3A, just like we talked about, I think observation for the most part is going to be favored. When you look at the right hand of the screen, we have the same countries or regions of the world representative for 3B through 3D. And again, you can see a wide variety of usage, not just of completion lymph node dissection or nodal observation, but systemic therapy as well. And I think this is where we continue to evolve what is the right thing to be done. And there is quite a bit of variety in practice currently.
Thank you very much, Dr. Fetcher. I think we do still have a number of topics to get through. So for the panelists, if we can just try and stay on time for the remainder of the questions, that'll be great. So Dr. Mitra, very quickly, what are the considerations for adjuvant radiation for a patient with a positive sentinel node?
So the short answer is there is no established role, but just to kind of go through some of the thought process, we have the experience now in recent years of what the primary pattern of recurrence is for patients who undergo the paradigm that's already been outlined of not having a completion lymph node dissection with or without adjuvant systemic therapy. And it looks like nodal recurrence is a primary driver of early failure. We looked at the MD Anderson experience of patients who had a positive sentinel lymph node biopsy without a completion nodal dissection, and about half of these patients did receive adjuvant systemic therapy, typically immune checkpoint inhibition. And at about 2 years, we saw that 46% of these patients who recurred had a nodal recurrence in the absence of distant metastases. So it looks like nodal recurrence, again, is driving what's happening early on. Next slide. And we were able to look, and as this is probably not news to anybody, what are the factors that predict for nodal recurrence after a positive sentinel lymph node biopsy? It looks like patients who have LVI, patients who have a larger deposit size, and patients who have more nodes involved all seem to be at increased risk. So this led us to ask the question, is there something we can do that potentially doesn't have that high of a toxicity profile that can decrease this mechanism of recurrence? And to look at that, we kind of had the TROG study as background. And we knew from that nodal radiation can decrease the likelihood of nodal recurrence in a different disease setting. They're patients who had clinically positive nodes and who had a completion, or not really completion, therapeutic nodal dissection. And in that circumstance, there was no overall survival benefit, but there really wasn't that much difference in late toxicity either. And there was a significant difference in nodal recurrence pattern. It looks like radiation in this setting can decrease nodal recurrence by about 50%. Next slide, please. And so that was the rationale behind our designing the MELPORT study, basically postoperative radiation therapy for high-risk sentinel lymph node positive melanoma. We would not give sentinel lymph node positive melanoma patients radiation off this trial, but in this study, we're enrolling patients who either have lymphovascular invasion positivity of their primary, a 0.5 millimeter or greater positive nodal deposit. And this is from, we did some dichotomization of what sort of the cutoff is that seems to be associated with higher nodal recurrence rate beyond the 1 millimeter that we published. 2 or more nodes or extracapsular extension. And then patients who have a positive sentinel node with these criteria are stratified either to have received or not received adjuvant systemic therapy at the discretion of their medical oncologist, as well as by nodal basin, and then randomized to receive adjuvant radiation. At MD Anderson, we do typically recommend radiation be administered in 5 fractions with a little bit of a shorter course. And then we just assess for recurrence events and toxicity over time. So thus far, we've enrolled about 50 patients of 168, and we're kind of excited to see, can radiation have a role in this setting potentially?
Great, thank you. So going back to our case, our patient after her surgery underwent active surveillance. However, 3 months later, she developed recurrence in the parotid neck area. And so restaging scans showed the nodal disease, but there wasn't anything distant or intracranial. So Dr. Shannon, what are the considerations for management of a regional disease, a regional recurrence without distant disease?
Well, for patients presenting with macroscopic disease, the guidelines are fairly general and fairly straightforward. You've sold this as someone who's got no distant disease, but you first of all have to confirm that they do in fact have melanoma, so they need a biopsy, and we generally do that with fine needle aspiration. We consider core biopsy, particularly if we're looking for genetic mutation testing, which might help us with our adjuvant or neoadjuvant considerations. You do have to confirm that it is in fact isolated. So, patients who've presenting with macroscopic disease in the neck have got about a 1 in 5 chance of having something found on a chest scan and about a 15% chance of having something found in the abdomen. So we stage them all up front before deciding what we're going to be doing next. We do offer patients participation in neoadjuvant systemic therapy trials, and I'll cover that a bit more in a moment. And then they need an appropriate resection and be considered for adjuvant therapy has been discussed. You can move on to the next slide. The main consideration then, particularly in the head and neck, is what is the extent of dissection. For the general melanoma patients, for the axilla, it's a bit of a no-brainer. They need a thorough axillary dissection. In the groin, we're now arguing about whether we should be doing ilioinguinal versus inguinal, and there are trials that are looking at that. But in the head and neck, there's very old data out there which suggests that once you've got disease in the neck, the operation that's required should be comprehensive, because they're very often multiple nodes and they're very often involving multiple levels. But despite aggressive operations, there's still very high rates of recurrence in the neck, and there are features, particularly multiple nodes, extracapsular spread, those things that have been mentioned by Dr. Mitra before that predisposed to recurrence. Chris O'Brien, whose name lives over the building of one of the institutions that I work in, published a lot of data highlighting the role for modified and selective neck dissections, because he noted that doing more radical operations didn't necessarily reduce your risk of in-field recurrence, and the mortality is usually related to distant disease rather than the regional problems. In my hands now, a lot of patients who recur in the neck have had lymphoscintigraphy, so we know what their pattern of drainage is. And so we would do a therapeutic dissection where the extent is determined by the location of the primary and the pattern of drainage that we can have seen or can predict on lymphoscintigraphy. One of the other issues is involvement of the parotid. Someone in the Q&A has asked a question about whether the parotid should be involved. If you've got clinical disease in the parotid and if you've got a clinical disease in the neck and no disease in the parotid, you should really consider doing the parotidectomy as part of the dissection, particularly when you've got lymphatic drainage that goes through that area. For those that are clinically positive in the parotid but negative in the neck, Chris O'Brien produced a lot of data which showed that there's a very high rate of neck node involvement, and you should consider doing that neck. But it may be selective, and there's some recent data from our service which shows some of the patterns of distribution there, and highlighting that you can do selective dissections. If you've got a clinically positive parotid and a clinically positive neck, then obviously they need a very thorough operation. But one of the things you should consider, we can move on. These are the charts from the AJCC8 staging system. And that shows that even after, and then this is mostly surgical management, these data weren't really collected when we were using systemic therapy a lot, that even with relatively thin primaries and microscopic positive nodes, you've still got a 1 in 8 chance of dying from your disease. And if you've got very advanced disease, you've potentially got a better than 2/3 chance of dying. So the surgery alone is not going to be enough. Just moving on very quickly, Dr. Fletcher sort of mentioned the adjuvant therapy trials, but in summary, just keep clicking through that because we're running out of time. But overall, each of these large randomized trials show that there was about a 50% reduction in the risk of recurrence versus placebo. And this isn't long-term survival, this is just the recurrence rates in the neck. If we move on to the next, but one of the issues here is that not necessarily all of those patients are benefiting. Just one click. There's 1 in 5 of these patients that actually progressed before they got onto adjuvant treatment, so they weren't going to benefit from it. Those that did, 45% still recurred, so they weren't getting a benefit from it. And in those that didn't get treatment, 38% didn't recur, so they weren't getting a benefit from it either. So there's only a small proportion of patients that will benefit from getting adjuvant therapy, but all of them, one more click, another click. All of them get treated. They all get a year of drug. They all have to come to the clinic every month. They get lots and lots of scans. So it's a very expensive process. So we are leaning more towards neoadjuvant therapy because we've recognized that this is a high-risk patient with suboptimal outcomes. There are many benefits that neoadjuvant therapy offers. We'll just move on to the next slide. Just to summarize it very quickly, and I won't be able to give you all the evidence for this, but there is good evidence that there is increased anti-cancer immunity when the tumor is actually present, when the drug is given. The response rates from following the surgery give immediate patient feedback, and you're able to refine your prognosis because of those outcomes. And you can tailor subsequent treatment from that. It's a very good translational platform, and it gives an opportunity to rapidly test drugs because you're getting your pathological response rates after a dose or two, and you don't have to wait for years and years of development.
Thank you,
I'll
Dr.
stop
Shannon.
there.
Great. So very quickly, what if this patient had oligometastatic disease to the liver? So Dr. Fletcher, what would her treatment options be in this case? And Dr. Malloy, is there a role for surgery even in that setting?
I'll be quick. IPI-3, Nivo-1 would be my recommendation. Liver mets are a bad prognostic factor, even if it's isolated. And I'm going to have you click through, and I'll be brief with my slides. One of our pivotal protocols for this is Checkmate 067, which randomized patients in the first-line setting metastatic melanoma to Ipi-Nivo versus Nivo versus Ipi. And again, I want to emphasize this was not statistically powered to compare Ipi-Nivo to Nivo. So we can compare Ipi-Nivo to Ipi, and we can compare Nivo to Ipi. And there were co-primary endpoints of progression-free survival and overall survival. Can you next slide, please? At 6.5 years of follow-up, one more click for me. We have a response rate, and this is what I referred to earlier in the first-line setting. Response rates of Ipi-Nivo are approximately 50 to 60%. One more click for me, and we have an overall survival benefit with approximately at 5 years, 52% overall survival benefit in metastatic melanoma. One more click. So then another concept is, what is the treatment-free survival of some of these patients, right? Is it better and better quality of life that they get treatment and then they actually have sustained improvement? And this is the selling point for immunotherapy. And so for patients who are still alive at 6.5 years in all of the groups, the red is Ipi-Nivo, the blue is Nivo, and Ipi is the green. the duration on treatment was the shortest for ipi-nivo, but the median treatment-free interval was greatest for ipi-nivo, meaning those patients in the darker colors had been treated on study, remained under control, and did not receive subsequent therapy. Couple more clicks. This is some work that came out of Michigan with our group. And so one of the concepts is that liver metastases can actually augment an immunosuppressive environment within the liver. And so if you think about the concept, this is in mouse models of siphoning out CD8 T cells from the peripheral blood, it then creates these, or we then have an increase in macrophages, which can lead to T cell apoptosis within the liver. And so this was the basis for a study that's ongoing here using hepatic ablation, where we believe that radiotherapy might augment the immunosuppressive environment in the liver. And we're pairing that with ipi-nivo, depending on the response after the first dose of ipi-nivo. If patients keep going, if patients aren't a candidate for ipi-nivo, another option might be relatlimab, nivolumab. So this was recently FDA approved a year ago. This did not have a statistically significant improvement in overall survival compared with nivo alone, but the response rate and the progression-free survival was greater with a better toxicity profile than ipi-nivo. Keep going. And then a couple more clicks, perfect. DreamSeq, if we start saying we have somebody with a BRAF mutation, what should we pick in the first line setting? DreamSeq, ECOG Akron 6134 was a randomized first line study that compared ipi-nivo in the first line setting versus dabrafenib, trametinib in the first line setting with, at the time of progression, switching to alternative treatments. Next click for me. Couple more, keep them coming. There we go, stop. This was terminated early for a clinically meaningful difference in overall survival at 2 years. The survival for patients who received first-line ipi-nivo was 71.8% compared to 51.5% for patients who started with BRAF/MEK inhibitors. And you can see progression-free survival as well as duration of response. So in general, we think of immunotherapy in the first-line setting as the best choice, even in the setting of a BRAF mutation, unless there are prohibitive circumstances for receiving immunotherapy. I think I have maybe, and then this is another emphasis. This is a long-term, lifelong cancer, in my opinion. So even patients who had a fantastic response to ipi-nivo, approximately 46% of patients in the ipi-nivo arm on Checkmate 067 required some other subsequent therapy for their cancer. So these patients, I would advocate, even when you have a great response, require ongoing monitoring and potentially additional treatment. Thank you.
Thank you, Dr. Betcher. Dr. Malloy?
Well, thank you. I'll keep it super quick. I think the role of surgery is occasional and a very unique situation. We obviously would, as Dr. Fetcher, who is my colleague and friend, we go initially to appropriate systemic treatment, as she has outlined. I think when we're thinking about surgery in patients with distant metastasis, we have to think about what their symptoms are currently, what their future symptoms might be, or their impending concerns, catastrophic concerns. These are highly unlikely and rare, but they do occur. And there are situations in which patients are experiencing a great deal of pain, can have nodes that might be, progressing and breach the skin barrier. There might be palliative reasons to consider surgery. However, these are individual cases that we talk about at our multidisciplinary conferences, work together as a team, and obviously incorporate the patient's goals and perspectives, given that they are in a situation where this is now a lifelong, chronic disease, and we have to keep appropriate goals of care in mind.
Great. So going back to our patient, multidisciplinary team discussion was considered, and all these options were listed. And the patient consented to go on the NEO-COMBI trial. So Dr. Shannon, could you tell us just a little bit more about this trial?
I'm a bit brief about this. So this was a neoadjuvant trial for patients who were BRAF positive to look at the response rates with a few doses before surgery. At that time, we were giving it for 12 weeks. Most of our neoadjuvant trials now for a much shorter period of time. The significance of this study, though, it had a very high response rate. There were no progressions through treatment. 14% of people had stable disease, but all the others had some sort of response. If you move to the next slide, and I'll just bring up everything on screen. So the NEO-COMBI, and in fact, the graph on the right includes some other targeted therapy trials. This is from the International Neoadjuvant Melanoma Consortium pooled analysis. But what it essentially shows is that the whilst the response rate, a complete response rate, shows an improved prognosis for those that don't have response with targeted therapy, there is still recurrences over time. When you look at people receiving immunotherapy as neoadjuvant, any sort of response is associated with a good outcome. Just move to the next one. Just click it through. Yeah. And so for the targeted therapies, there's a reasonable pathological complete response, but there are many that recur and they occur late. For the immunotherapy patients, there are a few of them and they occur very early. So as with the adjuvant therapies and the systemic therapies, our medical oncologists are much keener to give immunotherapy now up front and keep the targeted therapies in reserve, because the response rates in neoadjuvant therapy are actually very similar for immunotherapy, even in those people who are BRAF positive. So I'll leave that there.
Great, thank you. So for our patient, she had restaging scans and she had a partial response clinically, but there was complete metabolic response noted on PET, and she didn't have any evidence of distant disease. So Dr. Malloy, at this point, what treatments would you offer her?
So at this point, we would discuss with, and if you could go back just a quick moment, with the partial response, and complete metabolic response. We discuss her case at tumor board. I'd be interested in Dr. Shannon's opinion also as to, workup of this and, what you would do with what is often a, equivocal response on, sorry, I'll just finish the sentence real quick.
Yeah, sorry.
That's okay. On, what is often an equivocal response on, FNA, et cetera. I mean, and we would talk about doing, operating at this point if this is her only site of disease. So sorry, go ahead.
No, that's fine. Well, she was on trial and the plan was always to operate for her. And at that stage, we really didn't know what what a metabolic complete response meant in terms of pathological response. So she was always planned to have an operation. But the great advantage here, if I'd operated on this girl up front, she would have had a facial nerve resection, because it was a very extensive tumor, and I was able to, and while I did a facial nerve preserving operation, there was still macroscopic disease to feel, and that's one of the issues in operating on people in neoadjuvant trials is, if they've got something there that's stuck on the nerve, do you need to take the nerve? But I gave it the benefit of the doubt. I think she still had viable tumor, but we were able to save her facial nerve. Yeah. But we wouldn't have observed a lump in the neck, I don't think, at the time that she had finished her systemic treatment.
So she did undergo surgery, as Dr. Shannon had said. She had facial nerve preservation and superficial parotid and neck dissection. You can see these beautiful intraoperative photos here. And her final pathology did show that there were 3 positive nodes in the parotid, but nothing in the neck. So just very quickly, Dr. Shannon, how would you surveil this patient now? And how would this differ from your surveillance of patients with local disease only?
Well, our surveillance now is often driven by what's on the clinical trials. These are the NCCN guidelines as they stand at the moment, which give you a little bit of leeway, but essentially they would be seen every 3 months. They get physical examination, obviously assessing the nodes, assessing the primary site, asking for symptoms that might suggest systemic disease. We image these people very frequently now, and they would usually get scans every 3 months, not necessarily always PET. Our standard staging is whole body PET scan and MRI brain, but our medical oncologists tend to alternate, and they'll do the PET one trip and the anatomical scans, CT scans on the other occasion. So earlier stage disease, the frequency of the clinic visits isn't changed that much, but I wouldn't rely on imaging for my earlier stage disease. And for the low risk T1s in particular, I only see them every 6 months. But essentially we'd be following the guidelines.
Okay, great. So just to finish up our patient case, she has a happy ending. So she continued on her targeted therapy for 9 months, unfortunately developed a regional re-recurrence. initially was monitored, but then developed some small bowel mets that was resected. She was on some adjuvant treatment following that, but that had to be stopped because of some immune hepatitis. And then the residual neck soft tissue nodule was excised. It was noted to be 9 millimeters. Soft tissue deposit, negative margins. And to date, 5 years later, she still remains free of disease. So I'm going to end it here. I want to thank our panelists again for such a lovely discussion and really thought-provoking review of the data that we have for a very difficult disease to manage at times. Our panelists here put together a list of some key articles for our audience, just as some reference points to look at as you continue to treat these patients going forward. So again, thank you to the panelists, thank you to the AHNS, and thank you to all of the participants for staying on with us a little bit over the hour. Have a good night.
Thank you.